Good afternoon, everyone. Welcome to all the attendees who have joined in for this panel discussion, and to the speakers as well who will be here with us for the next 60 minutes and sharing their expert views. Throughout this course of entire month, we at Voice of Healthcare, in collaboration with Viatris, have been taken an initiative to mark National Cancer Prevention Month by conducting a series of panel discussions. In the same line of context, this yet another panel discussion while we are almost towards the end of this National Cancer Prevention Month. In this panel discussion, our experts will be talking all things important when it comes to accessibility of drugs, accessibility of treatment and diagnosis, and also the interventional strategies when it comes to cancer prevention. And to talk about it, I have a set of very expert set of panelists. I'd like to introduce them. We have Dr. K.P. Sahu, who is medical oncologist at Silver Line Hospital, Bhopal. We have Dr. Priyadarshini Nayak. She is consultant medical oncology at Some Ultimate Medicare, Bhubaneswar. We have Dr. Sachin Gupta with us. He is associate director oncology at MAP Super Speciality Hospital, Mohali. And Dr. Nitin Yashas with us. He is medical oncologist, Manipal Hospital, Jayanagar and Sarjapur Road, Bangalore. While sharing his expert views, Dr. Nitin will also be leading the conversation and the round of questions with us. So, without further ado, over to you, Dr. Nitin. Please take it forward.
So first of all, thanks to Voice of Healthcare for having all of us here. This is indeed the National Cancer Prevention Month, and of course on February 4th, we celebrated the World Cancer Day. I'm really fortunate and privileged to be on this panel with such distinguished and experienced medical oncologists across the country. So we'll kickstart this conversation by asking Dr. T.P. Sahu and really setting the sort of the tone here that we know that in Globocan 2020 data, it's almost 13 lakh cancer cases, new cases in the country, and we have almost 8 lakh deaths due to cancer, which is occurring every year. So, sir, where in your vast experience, do you think that there has been an increased awareness about cancer, and where exactly do we stand as a society in being aware about cancer?
I feel in my practice for last, let's say, 2 decades, things have changed and the change has happened in a positive manner. But there's a lot to do, at least in India, because the focus, what I feel, is the myths of the cancer has not yet been broken in the society. That's a point number one. Point number two, what I mean to say is because patients still are coming in a late stage, until all of us can shout over the rooftop and tell cancer is curable, but till people see those patients in the street out there being treated, being cured, the belief wouldn't be there. And that can only happen if we are letting and treating stage 1, stage 2 diseases more. So that is the proof of the cake is the eating it. That's what how they tell it, the little cake or a pudding, whatever you say it. But my point always is, I always tell and speak to my colleagues that till we start treating early cancers more and more patients are there living and cured in the neighborhood, we can shout the cancer curable, people still will not believe us. So third point, what I still believe is the focus. I am speaking on a very apolitical platform. So the focus, I think, is not is somehow being skewed in the higher hierarchy of the administration. It should be more on the prevention and early diagnosis rather than on the treatment, because cancer once stage 3, stage 4 is a huge costly affair. India, to my knowledge, I don't feel it's ready for that amount of expenditure, and treating cancer is much more costlier affair than preventing cancer or diagnosing them early. So this is what I think. But yes, over the last 2 decades, my experience has been pretty encouraging, positive, and I feel more and more patients are aware of cancer diagnosis. They are ready to get treated. And although one-off case every day in my OPD, I see patients not ready for biopsy, going away telling the biopsy might spread the cancer. These all outliers will be there, but most of the patients have started realizing that for a cancer, you need to be diagnosed, you need to do a biopsy, you need to go to a specialist and take the treatment.
I think a very valid point made, sir, that lot of myths about cancer, from it being a terminal disease, from biopsy, like you said, increasing the risk of spread of cancer. And then many people say that why should we even get imaging done to diagnose cancer? Or we have the other extreme where people say, let me just do a PET CT to find out cancer. So coming to you, Dr. Sachin, in your experience, sir, what is the trend of the number of patients or the percentage who present to you with a screening detected cancer as such, as opposed to someone being diagnosed, as Dr. Sahu said, in the advanced stages? The ICMR data says that less than 1/3 of cancers in India are diagnosed in early stage, and most are presenting with loco-regional disease. So what is your experience in this matter, sir? Asa, you're on mute. I think you need to unmute.
Sorry. Yeah, Nitin. So first of all, I would like to say that I resonate with each and every word of what Dr. Sahu had just said, and regarding the discrepancies in the care and the need which has arisen right now. And regarding your question now, so the screen detected cancers are still dismally low, according to me, and majority of patients are coming after having symptoms, and usually still the a greater number of patients are in advanced stages, stage 3 or 4. The early stages patients we are seeing are mainly confined to few malignancies such as breast cancer and some of the cervix cancers, and otherwise majority of rest of the malignancies are usually advanced, especially the GI malignancies, the like pancreatic, gallbladder, the stomach cancers, lung cancers, even head and neck cancers. So we are usually seeing in the advanced stages. So the screening is, again, it needs to be taken up in a big way. And as Dr. Sahu has put it, that we need to focus more on the preventive aspects. And so the screening really needs to be pushed up, especially for, preventable cancers such as head and neck cancers, right? So they can be easily diagnosed just by visual examination of the oral cavity and the throat in routine OPDs. So that doesn't require, heavy setup and heavy equipment at all. And it's tobacco related, and it's very rampant in our country. And nearly 50% of the cancers are 40 to 50% are tobacco related, and in a lot of regions. And so they can be prevented, they can be early detected and treated in a less costlier and less problematic manner. So the focus should be on prevention and early detection. And again, I would like to add another point is that the delivery of cancer care in our country is uh, focused in mainly the metropolitan areas. So like regions like Delhi NCR, Mumbai, Hyderabad, Bangalore, Chandigarh. So you will get 15 cancer centers in a 20-30 kilometer radius. And then there are vast stretches in our country in states like Uttar Pradesh, Bihar, Jharkhand, and a lot of other areas where there are no centers for 250-kilometer radius. So again, we need more regional cancer centers and like tertiary care for treatment also in these regions. So the focus should be to develop cancer centers in these regions as well.
I think Dr. Sahu wanted to come in for a point.
Yeah, just a small point. For the question which you asked, in my limited experience of around 15 to 18 years in medical oncology now, I feel that the screening detected cancers is something which I see once in a blue moon. I would see some 7 or 8 cancers probably screen detected, not even screen detected, accidentally detected. They would have gone for something else and the ultrasound has picked up something like a renal mass. The most common thing which I see nowadays is the blood CLL. You just go for a blood test for something and then you see the lymphocytes, asymptomatic things. So point number 2 is the discrepancy in the cancer care is also based on a myth. The myth is that if I go to a metro, I'll get the best possible treatment. If I stay back in a tier 2 city, tier 3, the treatment is not as good. So that also needs to be regulated at some point. I don't know how it's going to do. It's easier said than done. But once that, what Sachin told is a real problem, but that problem only can be solved if patients have the confidence to stay back. And that data, I think, from the COVID time when people could not travel to metro. And that's something that will be very, very nice to see. Did the tier 2 cities, tier 3 cities deliver good cancer care? And I'm very confident they did. and that should give government the confidence to develop more cancer centers in the tier 2, tier 3, and the remote places.
Coming to Dr. Priya, we know that the most common cancer in India across both sexes happens to be breast cancer. And also you see in women, it's all the top three cancers are the gynecological cancers, breast, cervix, and ovary as such. In your experience as such, is there still a stigma associated with cancers in women that despite being some of the top incident cancers in the country, we are seeing a lot of factors associated which is preventing women from seeking healthcare that they present at a late stage?
Yeah, very rightly asked. Actually, yeah, many patients, I find many females, they are very scared, to get even if they develop some symptoms, they don't know if it is actually suspicious. If it is like actually they should seek care, like seek a doctor for examination or something because they don't know, they're not aware. And mostly it happens in rural areas because see, I am practicing in Odisha now. I have come back to Odisha, and I find in rural areas people are not aware of these symptoms. What symptoms they should actually go and seek a doctor's help. They don't know that. They mostly from rural areas we find that patients come at a very high stage, not only very advanced stage, but in a very bad state of like fungating lesions. Even I find some cases come with maggots coming out from their breast lesion, which was when I was practicing in this Delhi NCR in Gurgaon. I never found such cases. I mean, because this is because due to lack of awareness, lack of stigma, they develop some lesion in the breast, they don't show it, they hide it. And when even I find families, they say that she was hiding it since 1.5 years, and we could smell very bad. Then only we searched what is that. Then we found that she was having this fungating lesion in the breast. Even such cases I find. I mean, this is due to lack of this they cannot the stigma of telling about the genital areas or any breast lesion. Even cervical cancers we find in advanced stage because still there is like talking about genital areas is a very thought to be a stigma in our country still now. But the good thing is that in advanced like cities, we find like in Bhubaneswar, people are coming. Actually, young females, many young females do come to my clinic in because I am a female oncologist here. Because we are only two female oncologists in our state. So now female medical oncologist. So now I see these females come, the very young females, they come and they do screening examination for their breast. This because I get involved in TB awareness programs, and also they actually come up to the clinic and get their examinations done, and they do a screening test. So that's a good thing. I mean, things are improving, but still we are lagging behind somewhere. I mean, we need to this close this care. I mean, this care gap that as our theme in this
World Cancer Days, yeah.
World Cancer Day, yeah, because in rural areas still the patients, they are in a very bad state. I mean, we need to go and aware the patients. We should reach to the patients out there. That should be our motto because they need to be made aware.
I'll just come up to a point that our next point of discussion, what Dr. Sachin brought about and what Dr. T.P. Sahu also discussed briefly, is the sort of confidence which is lacking in tier 2 and tier 3 cities. Dr. Sachin, what do you think are the factors that, for example, despite one of premier oncology institutes being there in West Bengal as such, we still see a lot of patients from West Bengal coming to the south for seeking cancer care. What do you think are the factors that are responsible for people to sort of not have faith in the centers in tier 2 and tier 3 cities?
So some things happen conventionally. So by the time the institutes came up and the newer centers came up in like you said in West Bengal, so traditionally and conventionally, patients have been traveling to like places like Bangalore, Hyderabad, Chennai, and even to like Tata Memorial, Mumbai, for that matter. For so over generations, so last two generations have been traveling actually. So there is a word of mouth thing that you go there, you will get cured there. So that faith is fixed for the for these cities. So traditionally, patients have been traveling. So it will take some time, and the patients would and the population there would have faith in their own regional centers. And I think it's a matter of time. And of course, we need more centers everywhere because it's a huge chunk of population, huge like number of patients who need to be treated, who needs attention of these centers. So this phenomena is, I think it's a it's a matter of time actually. So things would improve.
Dr. Sahu, do you think that the government needs to do, or more than the government, the institutes themselves need to showcase and put out the success stories of treatment being done in regional cancer centers? Because many often at the private institutes, we do that. And there's a lot of awareness, like you said, that we do put out cases to show that cancer is curable. But do you think somewhere the responsibility and onus also needs to be on the big trust institutes or the regional cancer center institutes to drive that faith in people?
I look at this problem to be, Sachin told one of it, that traditionally people have been going to the metros and that's how it has been for generations. But there's a problem which is, I think, can be solved. It will take some few years, maybe 1 or 2 decades, but it has to be multi-pronged approach. It has to be from the state governments, the central government, and the institute and the local doctors. 4 things which I'm talking of. Let's see why the local doctors can do. The first thing, let's start with central government. We should have a national cancer policy where the treatment should be standardized. It should not be as per the cost. It should be more like the UK or some protocols which are very, very clear that I get the treatment at hospital X, hospital Y. The treatment is standardized. That's the national cancer treatment for stage 3 breast cancer, triple negative. I will get the XXY combination and then I'll go for it. So that gives the confidence that wherever I go, I will get the same treatment. Point number 1. Point number 2, like institute like Tata Memorial, they were primarily, what I feel, they are doing lovely jobs. And one of the best articles are now coming from the evidence-based medicine is coming from TMH in last 5 years. I'm very proud to say that I know most of them, and I'm a proud colleague of theirs because they're generating data from India. And I think that should be left best to them rather than they look at early breast cancer or a stage 4 breast cancer and just spend their time on that. So Tata Memorial, like hospitals which are across maybe 7, 8, should become a referral center. Means only if a person who's an oncologist has referred and who needs an opinion, then only you come to us. Otherwise, we don't want to be burdened with this cases which can be done easily at your home place. That policy is very important. It might lead to uproar, but I think in 1 or 2 years, people will realize some centers are meant to do superior jobs like research and better skillful surgeries rather than treating everything that can be done in local place. Third thing is that I always strongly believe that the state government, most of the fundings are done from the state government. And the state government should only refer to case outside a state if that thing cannot be done in the state. And that should be in black and white, irrespective of the class, culture, and money. If you're using a state government money, you only go out of the state if the state does not have and does not treat. Like, I feel very sorry when a government spends money on treating a stage 1 breast cancer and doing it in Mumbai. So that's, I feel, is a waste of the resource.
I think we just lost Sir's
Hello.
internet connection. Yeah.
Hello.
Yeah, we got you back, sir. Yeah, we just lost you for a bit, sir.
Hello.
We can hear you now. Yeah, we can hear you now.
Am I there?
Yeah, we can hear you. Can you hear us, sir?
Okay. I cannot hear you actually. I'll rejoin. Please, you carry on with the other panelists.
So the point that Dr. Sahu was bringing across was very
Please
valid.
carry on with the other panelists. I'll rejoin.
Sure, sir. So, Dr. Priya, you also brought about a valid point, and that's something which maybe is not talked about more in India in terms of gender equity as such. Do you think that having more representation of female oncologists would also go a long way in bridging the care gap? with the community and the society, given that the gynecological cancers such as breast cancer are the top cancers?
Yeah, definitely. I mean, many patients, since I have come to, like, it's been 3 years, I have come to Nature, and I really, patients come and say to me, Madam, see, because we, some village, like rural people, like ladies from rural areas, they come and say, Madam, there were all this male surgeons over there. We could not, that's why we did not, got our this breast lesion examined or something. And even I mean, the young females, very young females in their 20s, if they find any like suspicious like lump or breast lump, that might, most of the cases might be benign, but they were like they were hiding it out, but they would come to me and get examined. I mean, they find very comfortable with a female oncologist as compared to a male male person. So definitely we need more female oncologists, at least for this female cancers. Even many of our this normal male patients also, they find it comfortable with female oncologists. They find them softer. I mean, I don't know, but they prefer. They say we prefer female oncologists better than male oncologists. I don't know
Dr.
about my
Sahu
male
is
colleagues.
seriously shaking his.
No. This is the ideal problem. See, we are taking the problem the other way. We first thought that okay, females are lesser in the society, we should encourage. That's the way, because I have a daughter and I want her to succeed in life. That's point number one. The social justice and the equality should be there. But I always strongly believed, and I tell my patients, a doctor is neither a male or a female. And I can tell you that I at least see 5 to 8 young females of below 25 coming to me for the breast problem. The point is confidence. If they feel you are good enough and they feel that you have a decent name, you will not unnecessarily treat them, then they will come to you. So lastly, which I want, and I agree to some point, that yes, the female will feel comfortable with a female doctor. That's no doubt about it. But if you look at it, like a state of Odisha, where I originally belong to, the famous gynecologists there, all of them are males. So, and the ladies I have seen have a waiting list for the male gynecologist. So, what I take from this message is, if the patients have a confidence in you and you are doing good, they will come to you irrespective of male or female. The softness thing, I totally disagree with my fellow co-panelists, because I've seen this is a personal thing. I've seen many male doctors who are very rough in the attitude. I've seen more female doctors very rough in the attitudes. So that is something that is very personal. I would not subscribe to the thing which Dr. Nayak spoke, but I totally feel that we should not encourage this one thing, that a female should go to a female, and that thing I think will lead to some issues, and that is something which I always fight, because lastly, most of my case of breast cancer.
Just as a counter to that, sir, I don't think like the aim was to say that a female should go to the female, but I think sort of, especially in rural areas and tier 3 cities as such, we believe that this may be a problem, that because there is more of male doctors than female oncologists, one of those reasons for cancers presenting at a later stage is probably, if there was a female oncologist, they may have presented earlier, only because of this sort of socio-cultural factors.
I disagree for two reasons. Not this issue of advanced cancer is mainly because of awareness. If that would have been the issue, oral cancer would not be coming to us in a late stage. So, and oncologists, I'm very sure none of our oncologists who are qualified as a DM will ever go and practice in a village. So let's be very clear on that fact. So my point is, you have to look at Anganwadi workers, train those workers, train the village PSC levels, so that they can refer this patient at the right time rather than delay the referral. That is what I was coming to, that the government has to act multi-pronged, and we only can do a part of the job.
No, exactly. I was telling that it really need not be a female oncologist as such, but rather the oncology team consists of community workers with whom the public feels more confident and do. I think having a female representation in the oncology team may overcome this sort of barrier as such. So let's getting Dr. Sachin in here, that, and that's something that we have already touched upon as such, which is the sort of discrepancy in cancer care which exists from institute to institute and from city to city. Now, I feel that there may be no right answer or wrong answer to what are the reason for this. There may be times when we certain oncologists or the perception is, oh, this regimen is too toxic, we may not be able to give, we may not be able to support if the person comes back with toxicities. Other times it might be an issue of resources being available. What really do you think, sir, is the reason for such discrepancy to exist?
So this discrepancy has been there for many, many decades. And so in look, we have, our country is very vast, and we have too many realms of various economic conditions, and some states are affluent than other states. And so centers, as I said, were have been traditionally, they grew around metropolitan cities. And so some of the northern states which have been economically backward, so very few centers could come up in those regions. And so now the impetus for improving these conditions lies on the part of the government as well as the private sector. So we can't say that only government is going to do it. So government is doing its bit, like in Kashi now, there is upgradation of the cancer center recently, and so many other centers and regional cancer centers are coming up. But private sector also has to come up with the cancer centers. And the problem lies with the cost of the medicines. Now, what is happening is that in our country, the services are not costly. The room rent, the cost of the bed, the fee of the doctor, nursing, all these things are, very reasonably manageable. So these things are not costly, but there is huge uh, difference in the, let's say, the cost price of the medicine and the MRPs of the medicines. So here lies the main problem. So if there is some kind of control over the pricing of the medicines, then this difference in the cost can be countered. Like in let's say Tata Memorial Hospital, so the cost of the medicines is highly subsidized. Every routine person can handle this cost, and there are a lot of charity work also going on, a lot of help from organizations going on. So similar things can be replicated in other centers. And if the government agencies can control the MRPs of these medicines, because there's a huge margin in the cost price and the MRPs, then the overall treatment of cancer, and the cost which gets escalated due to the cost of the medicines can be highly subsidized and controlled. So this is one area which needs to be actually controlled, and only the government bodies can control this. So some pricing policy where the percentage, the pricing from the, like, cost of production and the cost to the dealer, cost to the retailer. So if all these margins can be controlled, then the actual prices of medicines would not be high, and
I
here
think
patients will benefit.
I think it's a very important point of medicine, but more from a perspective matter, Dr. Priya, you said you were practicing
And
before.
another important,
Sorry, sir. Please go ahead.
yeah, so another point I wanted to add was uh, the insurance schemes. Now the center and state governments have, they are doing a lot, like Ayushman Bharat scheme, etc. is there. But now in these schemes, the pricing they have kept is so low that the, if a private person, your private hospital, treats under these schemes, then they are actually not, making any kind of profit here. So it's detrimental for their profit and their work. So these establishments cannot work on Ayushman Bharat and similar schemes from state governments if they go with the pricing policy what governments have proposed. So there the cost of services need to be hiked up. And of course you can control the cost of the medicines, but the services cost is negligible here, and it doesn't suit the private hospitals.
So,
So once we have a better,
definitely, I mean, the insurance part is something which we are going to come very soon in our next
yeah.
round of discussion. But Dr. Priya, coming to you, you said you practiced in before in the Delhi NCR region, and now you're in Orissa. From purely a treatment perspective, do you think that sort of the city or the institute you're working in would also determine what regimen you choose? So, for example, dose dense versus conventional, or let's say choosing folfirinox regimen as adjuvant for pancreas versus choosing something less intensive. So purely from a scientific rationale, leaving apart the cost side, what would your experience be? That do you think that when we are talking of standardization of treatment, does the city you practice in, does the kind of socioeconomic status the patients come from, and also what kind of follow-up you expect from them influence your treatment decision?
Actually, like more than what city you practice, it's very important in a what setup you practice. Like, see, I was in Medanta, so we did not have any. Everything was like a patient could afford all kind of advanced therapies. Patient had their this insurances, that they had cash, that everything. But then I came to Bhubaneswar. Bhubaneswar, initially I joined at a medical college. The medical college, the patients who came, they were of very poor background. But like you said, you asked about the supportive care, like those days and how to manage those, the patients who needed supportive care. That was not an issue. But choosing targeted therapies for patient was an issue. Like in medical college, we had always like we could use like very few patients only could afford target therapies, and immunotherapies I could just in a span of like maybe 1.5 years I could just give like I could just prescribe two patients for immunotherapies. Though I had come up many patients who could be actually we could use immunotherapies, but yeah, that the therapy, because we are cost as medical oncologists, we know we have conventional therapies which are actually affordable by middle class people, but there are target therapies. I mean, it's very difficult for them to take that to afford them in a cyclical manner. So that becomes an issue. Then I came to a corporate setup here. It was a part of this medical college, extension of the medical college. But here again, we have, same patients. We have some like affordable patients in every city. So we have those slim patients here, and I could again, I mean, I have equal number of like maybe I could give all therapies could be given in a like upper hand, because we have your government support over here. The government schemes are there, and your they have some rich class, the economic the patients who have belong to higher economic standard. They also come. So I mean, I could now I can administer like this range of therapies.
Dr. Sahu, I mean, both Dr. Sachin and Dr. Priya have alluded predominantly to the cost aspect of the availability of medicines and with regard to the insurance. Do you think there are any other factors? Because I personally feel, I mean, looking at patients coming from tier 2, tier 3 cities, I sometimes believe that in those cities, the oncologists tend to choose a little less of more aggressive regimens, even though they are approved regimens, because of patients' education factor, the follow-up status and all, whereas in the cities we tend to be more aggressive. So would you have any different perspective on this?
No, I don't agree to the statement, for reason that I trained in Bangalore, and I then I practiced in Bhopal for last, let's say, 15 or 18 years. And I feel that the problem is twofold. One is that we as medical oncologists, who we are because we are trained in the art of chemotherapy and systemic therapy, we are the focus, we are the persons who can change the perception. And I think now this medical oncology, as the fraternity is growing in cities and tier 2, tier 3, these regimens, as you call it, FOLFIRINOX or the dose dense or the TPA protocol for head and neck cancer, are being routinely practiced. This, what you saw, essentially would have been from two subset of doctors. Those would have been older medical oncologists, probably, who were beyond 20 years or something, not all of them, some. And most of them in these cities still go and take treatment from a clinical or radiation oncologist. And that's where the dose reductions do happen more. That's my personal view. I may be wrong in that, but that's what I see. But once we as medical oncologists have started coming in and we started giving the right dose and people do tolerate, we rarely see mortalities now due to toxicity, although there might be admissions. I think that thing is now getting a lot of traction, and I think people are realizing there is a difference in getting treated from a qualified and experienced. There's a difference in that two things. Number two is the cost of medicines. I think there is two issues here. The cost of medicine is definitely issue. I totally take your point of Dr. Sachin, but it's onus on the government to make sure all generics are of the equal quality. Till I have that confidence and I get a paclitaxel of 50 rupees, 100 rupees for a drug which I know has been costing few thousand bucks, it really, something is missing here. And if the drug was so cheap, what is the government doing for so long? And the point is the quality check happening? And am I assured of the quality check? Because I'm going to give this drug to someone who is being treated for cancer. So the onus is again on the administration to see that the generic medicines are of the highest of order and the generic policy is strictly adhered to. Because India, 90% or 95% of population takes generic as the medicines. And I feel government advertises a lot, but the quality checks, the onus is totally on them, and that is very important. The second thing what Sachin told, I totally agree. The medicines do cost quite a few of the patient thing, but for TMH, I would just want, I tell my doctor colleagues and friends, most of the government hospitals, the pay is not a worry. The pay comes from you and my taxpayers' money. So that cost also has to be imbibed in any protocol. Because I have found Ayushman Bharat, let's say in my state, the cost of treatment for getting treated in a private hospital and a government hospital, the government pays the same money. I'm very surprised. If government is paying for the infrastructure, government is paying for the doctors' salaries and the class 3, class 4 employee salary, how can the payment given to the hospital be same as in the private and the government? So ultimately, the government is spending more getting the same patient treated in a government hospital. That is something that worries me. That is something that needs to be refining of this. The Ayushman Bharat is a very good scheme, but the refinement has to happen. And as Dr. Sachin told, some of the surgical codes are too dismal. I can tell you, offbeat one rectum cancer surgery, any one of in the panel, can you think of getting operated in 30,000 rupees for the whole package of surgery, admission, esophagectomy is around 67,000 rupees. It's just something that needs to be reconsidered.
I think very fascinating and valid points here. Dr. Sachin wanted to come in. Please go ahead, sir.
Yeah, so just I wanted to add that regarding the point that the treatment decreasing the dose of the treatment and some of the regimens not being used in let's say smaller towns and cities. So Dr. Sahu has already said 2 points. So I like to add that it may happen like if the patient is not affording, then the doctor may not want to create more toxicity, that. So according to patient's background, economic status, sometimes doctors may choose lesser less invasive and less toxic regimens, which is fairly okay for that particular patient. And
And that's
otherwise,
Sachin, that's
yeah,
valid for even the metros. I think that is a social support which even
yeah,
they look into. I think that's
yes,
valid for all the places.
that's valid for everybody. And secondly, only the higher regimens like the high dose methotrexate, or if we have to give let's say the transplant thing, so those things can only be done in a highly specialized centers, and so which can be government, which can be private. But otherwise, most of the solid tumors regimens can be nowadays done in in a smaller setups. You need a trained person, a good medical oncologist to handle it. That's it.
And I think that's the point which we are trying to bring out, which is to give that confidence to the public and even to the oncology community at large, is that it is manageable to do a TPF or FLOT in a tier 2, tier 3 cities as long as you're confident. And because essentially when it comes to managing toxicities, it's about being a good physician. And it's really about that. It's not being an oncologist when you're managing the toxicities as such. It's about portraying that message out there to the public and even to the referral doctors as such, that yes, in a tier 2, tier 3 cities, we will still be able to follow the aggressive regimen, provided, of course, there is that socio-economic support that we are all talking about. But we are moving on to the next aspect, and that is something which has probably been talked about a lot and which Dr. Sahu brought about a very valid point, is about the insurance and government schemes. So let's say we have briefly talked about government schemes as such, but when we talk about insurance, and I would like all three panelists to pitch in, we still are facing difficulty in monoclonal antibodies, immunotherapy, and oral therapy in being approved by insurance companies. What do you think is the reason for this, considering they're all approved? And it still really baffles me because, just a few years back as a resident, we had to write those queries which come in the night for all these things. So what do you think really is the lacunae behind it, and what can we as a society do to overcome this? I will start off with Dr. Priya, and then we'll move to Dr. Sachin and Dr. Sahu. I think we just lost Dr. Priya there. Dr. Sachin or Dr. Sahu, any of you can take it.
Yeah. So now this is again a a very wide issue actually, and the problem lies with the, one thing is our society and the conventionally we are not, routinely we are not getting this medical insurances. The penetration of medical insurance is very dismal in our country. You can imagine that nobody takes a vehicle out of the showroom, be it a two-wheeler or a four-wheeler, without an insurance. But we, all of us, go on road without medical insurance. So one thing is, it should be made, wherever possible, mandatory. That, after a certain level, you have to get this thing done. But the governments are pitching up with their own insurance schemes, like Ayushman Bharat, and state governments are also pitching in with that. So there you need to make better codes, like Dr. Sahu had pointed out that, whatever surgery has to be done, there should be a proper, the code to that, that this much amount of money is valid for this kind of surgery and this kind of procedure, this kind of chemotherapy and all. Now, then coming to the personal medical insurances, now there is lot of things are written in very small fine print there, which nobody can go into detail. So which is very difficult. And insurance companies were not, ready. Till few years back, these high price medicines were not available. No, every few years there are targeted therapies, there are immunotherapies. Now they didn't know how to handle all this. So the insurance premiums were not built in to handle these kind of expenses by the insurance companies. So they try to deny this benefit to their patients by making some kind of excuse, which always is there in the fine print. So once you take a policy, you should ensure that, all kind of targeted therapies, immunotherapies, that is written there. But that is again difficult for a routine person, because I, being a very educated graduate, postgraduate, even I cannot go into those fine prints in the, there are huge documents. So this can be taken up at a policy level by the governments, that these things have to be there once you take insurance policies. But of course, the premiums are going to increase once you have high cost medicines inbuilt into your insurance schemes. So be ready to pay higher premiums.
Dr. Priya,
And
what would your experience be with these insurance companies as such?
Yeah, actually, as Dr. Gupta rightly said, definitely, the even the premium, the amount, like the amount they assure the patients, they are also very low. They are also like very low. They give, I mean, many patients who come to a clinic, they have this very this low kind of the amount they get for
some issue.
their treatment, maybe 5 lakhs or maybe like maximum 10 lakhs they could get. I mean, most of the cases in this thing, it is very difficult to include surgery, radiation, chemotherapy. These therapies could not be included in this the amount they get. And second point is that very like very few patients in our like in our country, in our, I mean, my city where I'm practicing, I mean, very few patients are like actually completely become completely insured. Either they take the help of these government schemes or like their corporate schemes which help them. Otherwise, like very few patients who get actually insured for their disease. I mean, and the disease amount, if they get insured, is very low, which we cannot give all the comprehensive, cancer treatment is very difficult. So it's a huge challenge. So at least for like if the policies, in my opinion, if they're including the cancer disease in their this thing, they should keep the amount bit higher, maybe 10-15 lakhs, maybe above 10 lakhs. Otherwise, treating up, giving the patient comprehensive complete cure is very difficult on our part.
Yeah, so one aspect is obviously the insurance limit, but if you start looking at the cities at least, and even among the middle class people or those who are working in BPOs and corporate companies, most of them generally tend to have at least a 10 to 15 lakh cover as such. But even then, let's say a stage 4 hormone positive breast cancer comes, and even if they have a 10 lakh insurance, they are not, the insurance does not cover the CDK4/6 inhibitors. So, Dr. Sahu, this is where I want to
Yeah.
get you in, that even if there is insurance limit, even people in the cities are not able to get access to targeted therapy, oral tablets, or immuno.
I look at it at a 3-point thing. First thing, I agree that insurance is a business for the person giving insurance, and it is their job to see and earn profit out of it. So we cannot deny them that. So how does it work? I feel the government again needs to play a role in this. The most important thing that government should play, as we did with the data services. You find India is having a very good data service because the TRI was very proactive in this. So it becomes prudent on the government agencies who are controlling the insurance to make it one liner, that you could have insurance of 2 or 3 types. One should have that anything that is approved by the Drug Controller of India cannot be denied. Let it be oral or an injection. That one liner will save lot of the trouble. And what
Perfect.
stops government from doing that? As we did with the policy for the mobile service providers. So that one liner is not a difficult job because your agency, the drug controller, only approved the drug. And if that is one liner is there, it just solves the problem. Then you can ask the insurance company that because everyone is not there, you claim it that you have different slabs, one for everything that is possible as per the approvals, that is included. One, you could give a simple basic panel where the targeted therapies are not there. So you that can be in the bold letters, and that does, and the premium can be charged as per that. So what I mean to say is, it is a problem which has been created and is being continued. I don't know for whose interest, but if that government agencies come in and the regulators put in that one liner, let the premium be decided, let the slab be decided, I think it is going to solve what you are speaking of. That everything that is approved on that day will be have to included. You don't have to write each drug separately. That's my thing, which I feel. And people who take insurances should not go on the agents who are doing the insurances. They should try to spend 1 or 2 days because that is their life that they are insuring actually.
So and just again a question, and this is a problem which is going on for so many years. Do you think, as a oncological society, is there something that we can do in form of representation, in form of petitions? Do you think that as a society itself, we need to come? I think we lost Dr. Sahu again, having some technical glitches. So do you think, as a society itself, is there something that can be done by us?
Yeah, so Nitin, should I answer this?
Yeah, sir, please.
Yeah. So Dr. Sahu has rightly pointed out that we need a advocacy from the patient side as well, right? So like there's a chambers for industry, right? So the industrial group goes to the particular ministry for their jobs done. So they put their perspective to the ministry that we want this particular thing. Like suppose in some industry there is the raw material is coming from China, so the industry will go to the ministry and ask that please put some anti-dumping duty or do something for us because our industry is not benefiting. So now here the pharma industry can go to the government, but patient side, there is nobody to represent the patient side, right? There is nobody to represent the public. So here, the oncological organizations, like in our country, we have ISMPO, we have, or even let's say the MCI or other medical bodies, state medical bodies, so they can jointly, put up this from the patient's perspective, that how the pricing needs to be controlled, what is required from patient's perspective from the insurance side. So there can be meetings on this, there can be representations on this, and Dr. Sahu has rightly, given a very simple solution to this, but somebody has to take it up at an organizational level with the government to ensure these things are done. So once the DCGI proves a certain thing, that regimen, how can the insurance companies deny that?
No,
So
exactly, and
something
that is what is so frustrating as treating oncologists that we have, which is why I mean both Dr. Priya and Dr. Sahu, I just wanted to get in your views also that as an oncological society, should we be also having a more responsibility and spending a little bit of extra time to encourage patients to also, like Dr. Sachin rightly said, patient advocacy, asking patients to form support groups and to put up representation and petitions. Dr. Priya and then Dr. Sahu.
Yeah, definitely. I mean, patients, they should, whatever, like, the hurdles they face during the treatment, may it be related to cost or claiming this insurance amount from the insurance companies. They should actually spread the word to their peers, to their friends. I mean, that can go a long way. And even while the policy is being formed or something, government policies are formed or government schemes are formed, they should at least, in my point of view, they should include a medical oncologist also, because in our many schemes, the government schemes, they come, they give us these regimens only you can use. Like we have a BSY scheme over here, government scheme. So they are give us as a 4 to 5 sets of regimen, that much you can use. So at least they should take a medical oncologist while forming these regimens. So at least we can choose some like better regimens for the patient. Like a patient could get better benefited. So while forming some like policies, they should in cancer, like in treatment of cancer, at least they should include a medical oncologist also. So that is because in most of the cases, while they form the policy, something the mostly radiation oncologist, I think they had included. So uh, treatment, we still lag behind getting the right treatment for the patient. So that is my
Dr.
point of
Sahu,
view.
what do you think can be done to just get that one line which you beautifully said? Anything approved by the DCGI cannot be rejected by the insurance company. What do you think as a society that we can do?
There are two, three things, and I look at the low-lying fruits, low-hanging fruits, and that's the easier thing because this will take some decades of work. First thing is that there should be a patient advocacy group which I strongly believe, and that should be out of politics. The problem is in our country, everything becomes political. And till that is there, then they will only toe the line of the government, and that is not in the benefit of the patient. Point number one, that thing has to be there in the disclaimer. Number two is that we as the society, like the ISMPO, ISO, all these professional bodies should be there, and government policy making, they should at least take the national body representative to be there in the committee. And number three, the proceedings of the meetings should be made public and should be transparent. Once it is done, it gives a lot of accountability to that. And lastly, we are focusing too much on treatments. In last 15, 18 years of my practice, as I've grown older, I've become probably wiser. I always feel that I have only 100 rupees with me. I have to spend the 100 rupees wisely. And I feel it is in screening and early diagnosis. Like if I were to spend that amount of money for tobacco control, I would spend that amount of money for cervical cancer pap smear, I would have spent that amount of money for probably vaccines against cancer. I feel we would have done a better job. In 2 to 3 decades, our cancer load would have decreased a lot. Lastly, we see so many ads and advertisements we saw for AIDS. I still feel, see, I can visualize Sabana Azmi coming down कि छूने से प्यार फैलता है, एड्स नहीं, HIV नहीं. That is a very minor what I
Iconic.
remember.
I think we again had some technical glitches with Dr. Sahu.
How many ads have you seen with cancer? How many ads have you seen on the FM? You would see one off, and we are only remembered on a World Cancer Day, the October 31st, and that's when media person will come to you and we do a press briefing. I think it's an everyday job, and we should be there in at least once a week, and government should be there advertising these things in the TV with big shots or more people who can influence the society, and then I think the changes are bound to happen and will happen.
No, and especially in US, like how we saw the Jolie effect, which came on the cover of the Times magazine. Just one huge celebrity talking about the BRCA mutation, risk reduction, mastectomy, and so much, just completely revolutionized the field of breast cancer screening in the United States of America. So that's the last part of the segment that we are talking about, is really about prevention and screening, and also a little bit of cancer research as such. So Dr. Sachin, starting off with you, like I said again, we don't have to look anywhere too far. In 2012, we all saw in US what the Angelina Jolie effect did. The rise in the number of women seeking care for BRCA mutation screening or mammograph or risk reduction screening. What do you think this country needs to do to A, increase prevention and screening, and B, to also inculcate a sense of research among the medical fraternity and the scientific fraternity, so to speak, the big institutes like IISC, NCBS and all, to start collaborating with clinicians to take cancer research forward?
Yeah, so again, we have multiple areas here to work upon. The first thing is the basic level. As Dr. Sahu has rightly pointed out, that the prevention aspect needs to be taken into the account first and foremost. So for that, we have a huge workforce at the village level, at the block level, the Anganwadi workers and the, there are junior workers who can be trained. And in this age of technology and the way we are having digital penetration and internet availability, even in smaller towns and villages, so this information can be easily disseminated to the village level. So this training, so we have a national training center which trains digitally through internet to the basic ground level workers that what needs to be done. So a series of training camps and online training can be done. And so these patients, we have to only spread awareness to the basic ground level worker regarding this. So the preventive aspects, the hygiene and the pap smear, and the early detection, the symptoms, all this information can be easily disseminated. We only need a good program and somebody running that program properly at the government level. And so this is at the prevention level and at the block and the village level. And now regarding the research thing, so in our country, we are nowadays we are producing a lot of papers, we are doing a lot of research. But now this research is mainly with the medicines which are produced in the by the Western nations. Look, their research system, their molecular level research and the targeted therapies they are producing. So we are not anywhere near that right now. That's a very very costly affairs, and that cannot be done by everybody. So it's a very focused thing, and so that can be jointly done by the government and the pharma industry. But again, the government priorities are for prevention. We have to understand that government cannot spend billions of rupees and dollars on producing new for researching for new drugs. And if the pharma industry does that, and of course they have to take out the profit of their whatever money they pump in to do that research. So that research is mainly has to be left to the private sector. And so of course that would be profit driven whenever that happens, and in collaboration with bigger institutes and research centers and medical colleges and institutes like Tata Memorial and bigger cancer centers in private setup also. So that is a joint collaboration. But the basic level research, you need that kind of research labs, which now Indian pharma is capable of because they are also multinational companies right now. But the amount
And
of money which
even
the Western.
apart from the pharma industries, I mean, I was just recently reading the story of the legendary Mansukh Wani, who an Indian by origin was responsible for the discovery of the paclitaxel and irinotecan derivatives in US, where you essentially have the scientific bodies trying to discover compounds which are anti-cancer agents, and then it is taken forward to the next level of development. But just an interesting aspect which I would like to ask Dr. Priya to come in is, do you find it easy to refer your patients to clinical trials happening in the country? Because if we sort of look at all NCCN guidelines or some guidelines, they always say clinical trials are advocated for this group. How easy is it in your practice to A, find a clinical trial, and B, to also refer a patient for a clinical trial?
Yeah, actually, see, we do have, in fact, there were very strict, guidelines when I was practicing in Gurgaon. We had lesser clinical trials happening over there. I mean, luckily we have more clinical trials. The companies are coming up with this more clinical trials over here. But you see, in our state, getting patients for clinical trial is a much easier as compared to the patients outside there, because here patients are poor. So many clinical trials, they make imaging free, and they also give TADA, like transport and all, also they do free for the patients, and treatment part is completely taken care of. So patients are very easy. If a good clinical trial comes up, I mean, for common diseases, for recruiting patients for clinical trial are much easier here as compared to the patients I used to treat in some bit advanced cities. So I think definitely getting more and more clinical trials by companies would be beneficial both for companies and for patients also. So we should come up with clinical trials more and more.
I think
Hi.
we'll let Dr. Sahu have the last word on this, on just three aspects: prevention and screening, research, and access to clinical trials.
Okay. For prevention screening, very, very clearly, we have to just see that oral cancer thing which Sachin told. From Kerala, there's a paper by just self-oral examination, you can reduce the mortality in oral cancer. Are we practicing it? Are we advocating it? Are we promoting it? No. So point is, the research from our country has shown something which does not need, patient don't need to spend anything. So point number one, we have to start believing and do things, because screening needs something which is very cost effective. I never felt mammography to be a very good screening program because it's still costly. And most of the mammogram centers are in the private. The point number two, we need to do with good amount of taxation to something that causes cancer. I know government needs money, but if something, the government is spending more money on cancer care than earning money out of revenue from that, I think we should be rethinking, and the citizen's life is also at stake. And that should be thought very, very carefully. That taxation has to be skyrocket so that people really cannot afford tobacco. And that's well documented data. Even alcohol, it's a class 1 carcinogen. There should be a lot of taxation to that part. Number three, research. That is again something, we are a media driven country. Most of the countries are now. And I was in the midst of the trial thing, which clinical trials happened in Madhya Pradesh some 10-15 years. It was in the all across the media. And at one point, I used to do the maximum number of clinical trials in oncology. All of them DCJ approved, all of them phase 3 multinational trials. I have been a PI for 48 to 50 clinical trials till now. But I didn't do a single trial after 2010 because the media hounded you. And then you feel, is it worth the trouble? And the thing that was put across is the clinical trial is something that really makes you a victim of the whole situation, guinea pig. And that is wrong. Ultimately, NCCN tells you at every footnote that clinical trials is the best way to treat cancer. Who told that? So that is something. Again, the government took a knee-jerk reaction, did some policies, backtracked, and that also did not play good to the international media. And also, rightly, our patients were deprived of the new drugs. So a lot of things have happened. So if I'm okay with clinical trial, yes. But what I mean, Nitin, is research. And the research should be original. I agree with Sachin. And lastly, which I want to tell is, we have to think with one thing. I'm ending that with the thought, food for thought. Most of the PhDs in US and the Europe are from India and China.
Exactly.
Why is that? They do not do the research here. If that can be answered, we have the brains, we have the money. If we can spend so many of other things, why can't we do on medicine research? So I feel it's just the thought process. Once we start prioritizing medicine, I think the research is going to happen. India has been a powerhouse for medicine all along. We just need to realize the potential. That's it.
And when we meet our colleagues from international countries in conferences and all, and we see that as students, they play a very key role in research. And recently, I was very glad to read a news that the Indian Institute of Science is coming up with a dual MD PhD program. And so maybe incorporating such kind of programs would be the way forward, where, like you rightly said, not viewing clinical trials as research, but original research that we can proudly say, yes, this is India's contribution to the field of oncology. And that is something that's a day that we all look forward to. And I certainly hope that we all can be part of. And just secondly, to highlight, I also feel that the government needs to do a lot more, and even as an oncological society, about a lifestyle-driven carcinogenic changes, be it diet, sleep, obesity, and more physical activity. Because most of us always talk about tobacco and alcohol, but in today's world, we know that especially in the metros, obesity and other lifestyle changes are also being viewed as carcinogenesis fact. So it was a wonderful discussion on this Sunday afternoon by very, very distinguished and experienced people. It was my privilege to be moderating this. Thank you so much, Voice of Health. Thank you, Dr. Sachin, Dr. Priya, and of course, Dr. Sahu, who for youngsters, we have been seeing you in conferences, and you have the same amount of energy and enthusiasm and the passion that is coming across. So thank you all so much. We look forward to meeting all of you hopefully very soon in the national conferences as it used to be before, and have this same exchange of ideas. Thank you all so much.
Thank you for inviting.
Thank you.